Hi, everyone, and welcome to another episode of Wellness Day, a podcast coming to you every Wednesday here from the Jehangir Wellness Center. My name is Kabas Jehangir, and here from the JWC studio today, I've got Dr. Manish Patil, who is a part of our neurology team here in Jehangir Hospital. Thank you so much for being here, Doc. It's a pleasure to finally have you.
Yeah, good afternoon, everyone, and thank you, Kawat sir, for the opportunity to have.
Absolutely, it's as I said, it's been a long time since I've been wanting to have you. We've had other people in the past talking about all the neurology related things, particularly like strokes and epilepsy and so forth.
Yes.
I thought today what a lot of people have actually asked us to ask a lot of doctors about is the more simple stuff, so to speak, the more common things, like, oh, I've got headaches or I've got migraines. So the people are asking those kind of questions. So I thought we'd think of talking about a little bit more about that. So they think about all these serious issues in neurology, but what are the most common everyday kind of things that come to you?
Yeah. So in the neurology OPD, the headaches, the backaches, the neck pains.
Right.
These are the most common stuff the people come up with. Amongst those, the headaches, which are like frequent headaches. These are one of the most common causes for which the patient comes to a neurologist. Because the migraine, which is a very well known form of what we call as a primary headache, why we call as primary headache? Because if you scan the brain, the MRI comes out to be normal.
Okay.
If you do all the tests are also comes out to be normal.
Yeah.
But the patient tend to have a very severe kind of headaches, and which are episodic and tends to have repetitively. For the years together, patients suffer from those headache. And why those bothers them is that it is very difficult to work with having migraine in the background.
Yeah. So, I've had that experience. I used to have migraine.
So that becomes very troublesome thing.
Yeah.
So the patients who are very who are having the migraine for years together, they know what kind of headache they have,
and how
they know what they triggers it, and for what duration they are going to have that kind of headache. So they know that how to avoid those trigger, how to cope up with that headache. But the patients who are very new into that migraine zone, let's say a young adult,
right,
who just had who started having headache for let's say 6 months now,
right,
and they are having headaches. They are studying, and whenever they try to study or focus, they tend to have the headaches. Headaches are very severe one. Few of the migraineurs have severe headache that they tend to have nausea, they vomit like anything.
Yeah.
They have visual disturbances. They have even before the migraine starts, they have poor or sad mood. They know that they are drained out, they have fatigue and all.
Yeah.
And even after the migraine episode subsides, they tend to have the very low kind of mood.
Yeah, it's like a hangover of migraine.
It's kind of thing. And it's very difficult to focus on the studies, on the work in that pace. That's when they come to a neurologist to take help.
But what causes migraines?
Yeah. So migraine, as we are told, it's a primary headache.
Yeah.
So there is no structural abnormality as such, but there are few theories why the migraine occurs. So for the simpler purpose, whenever the patient comes to us and asks us, sir, why do I have the migraine?
Yeah.
So in the layman terms, we can tell them that your brain is very much sensitive to certain triggers, for which the most of the patients are not that kind of sensitive.
Yeah.
So whenever there is a vasodilation, initially the theory was whenever the trigger comes, the vessels in the brain gets dilated. And because of that dilatation, the pain sensitive structures of the dura or something, they get stretched and they can have the headaches. They start headache and then propagates the headaches.
Yeah.
Now the theory is that the cortical spreading depression. It is very technical term, but they thought the kind of headache which starts in some part of the cortex and it spreads like a wave of depolarization. And it tends to have a severe kind of headache, which only triggers the pain sensitive structures in the brain. So whenever that passes, you can have the visual symptoms, you can have the nausea, vomiting, you can have the poor moods.
Right.
It's a severe kind of headache they have. And the specialty is that every person have a very different kind of headache and different intensity of headache. So why it is important that the person who is very well accustomed with his kind of migraine, if he tend to have a different kind of headache, they know that it is not my migraine kind of headache. No, it's a different kind of headache. Then it is the time for the neurologist to be alarmed, get alerted, and evaluate the patient thoroughly, and not to give the
SOS.
Yeah. that kind of thing, because the patient knows. You should listen to the patient when he tells you that, sir, I am having migraines for years together, but this time I think it is different.
Okay.
So when the patient utters those words, you need to like evaluate him thoroughly.
Right.
Maybe the imaging, maybe the thorough neurological evaluation, and give the like proper weightage to his like complaints and all.
Right.
Yeah.
And I mean, what are things that we can do to prevent migraines, and if you can't prevent them, what can you do to reduce them?
So exactly. So migraine is such a like prominent complaints in the migraineurs that whenever they tend to do something, there are few triggers. So most of the time, every migraine has few features which are common, which are called phonophobia, or which are called photophobia. Phonophobia means for the sensitivity towards the loud noises.
Okay.
Either might be the music or like the loud noise or anything like that. There are second thing is like sensitivity towards the bright lights and everything. Whenever there are flashy lights, and it can just trigger it. There are few people who are sensitive to skipping meals. This skipping meals, like if they skip the meal, they tend to have the headaches.
Yeah.
If they have a poor night's sleep, that can trigger the headache. There are certain foods which are very much known to have the trigger, the chocolates, the cheese, the kind of fried food.
Thank God I don't have that.
Yeah, so that can trigger it. There is one more thing which is very common in the Indian context is the osmophobia. There are certain perfumes, certain like incense-stick fragrances. Yeah. So the smell can trigger it. So we ask all of this factor, even the patient is not aware what is triggering it.
Yeah.
So for the every migraineur, we advise them to maintain a headache diary. So whenever they have headache, we give them the like prescription, we give them the medications. But whenever they are better, we ask them to go back to the episode when the episode started, and imagine what happened that time. So they come to a conclusion that whenever I have this food, I tend to have a headache.
Okay. Yeah.
Whenever I try to do this, like maybe the study for longer hours, maybe to go in the sun, sunlight without shades. So that time I triggered. So we just ask them to, can you avoid those triggers?
I was going to say, so the avoidant, or rather the way to prevent it is to actually know what your triggers are and try and work around them. So that's actually more like a workaround. There's nothing that you can actually do to stop a migraine.
There are certain things like what we call as a profile, like lifestyle modification. What we call as a migraine is more than a structural issue, is a lifestyle disorder.
Yeah.
So whenever you are having a poor kind of lifestyle, poor lifestyle means like if your diet is not proper, you're not having food on time, your food is not nutritious enough, maybe not enough proteins, not enough hydration, or if you're not sleeping on time, or if you're sleeping on time, the quality of the sleep is poor, or there are certain things, like certain triggers you're not avoiding, like having too much coffee in the day, if like having too much tea in the day. These are the kind of things. If you work on these things, so most of the time, the headache frequency comes down to so low that even the patient forgets that they are having a migraine.
Right.
So that is the thing. But to bridge to that level, we need to give sometimes the medication to trigger down, to get the frequency down.
Right.
So there are certain medications like let's say TCA, amitriptyline kind of thing, or like beta blocker, non-selective beta blocker, like propranolol, this kind of thing, or topiramate. These are the few medications according to the patient. So what are the, if the patient is too much anxious and not getting sleep, so maybe I would prefer amitriptyline over the beta cap. If the patient is very lively and does not feel that he's anxious or anything, something like that, but the pulsatility is too much, I might prefer the beta blockers over the amitriptyline. If the weight gain is the issue, then I cannot give the amitriptyline. I might have to switch to the topiramate so that the weight is also controlled, that kind of thing. So there are many factors to take into consideration.
Yeah, I mean, it's very interesting what you're saying. I'm going to blow my own trumpet a little bit over here, because I used to get a lot of migraines as well. And for me, the triggers were more, A would be bad night's sleep. And B, I remember it used to be, which is still actually the case, is that if I would do very, very vigorous exercise, it's like what you were saying, the dilution of the vessels and all that, and it would feel like blood is rushing to my head. And then if I had a really bad migraine, it would be like for 2 days, I'd just be, out and stuff like that. And that would happen, maybe 2-3 times a month. And then I started focusing more on my lifestyle aspects, like what you were talking about, about the exercise and getting and food right, and sleep. And then, once I started doing that, I realized that now I really don't get those migraines anymore. I still get them every now and then if I know exactly what I'm doing, which is came back to what the triggers. So like if I do a very, very hard run, I know I'm going to get one. So But it definitely has reduced to maybe, as like you said, I'll get them maybe once every
Yeah.
45 days or 90 days, or if I know I'm going to do a very hard run.
Yeah.
But as I said, it's not something I can avoid, but I have to sort of manage.
Yeah. So
around.
like any like of this chronic disorders, no. So
Yeah.
the information to the patient,
Yeah.
giving the information to the patient, giving the knowledge of the disease to the patient, gives them a sort of relief or kind of the confidence that they can like tackle with the disease. No, so like the migraine, the similar kind of headaches. No, there are few primary headaches like the same characteristics. No,
Yeah.
the MRI shows nothing, the imaging shows nothing. There is no absolute like abnormality in the like neurological system, but they have a headache. But it is not only the migraine. No, there
Yeah,
are like
yeah.
tension type headaches are there.
Right.
There are like trigeminal autonomic cephalgias are there. So there are certain kind of disorders. Even they look like migraine, but they have a very different kind of etiology, and the management like aspect changes.
Right. But you also made a very interesting comment before we started, is that you were saying something that, migraines actually tend to decrease
Yeah,
as
with the
you
age,
as you grow older.
So, like-
tell us a little bit more about
Yeah.
that.
So like most of the time the migraine starts in adolescent ages, no? Like 14, 15, 16 when the students are in the 8th to like 10th standard, when they are into like studying all, no?
Yeah.
They want to focus on the studies, the parents are pushing them to like have good grades and all. And that time they starts having headache, no? So everybody like blames it on the like they don't want to study. That's why they sort of making excuses, no? Not to studying, no? Okay, like I don't feel good, no, whenever I study. I feel like nauseating, the vomiting, and everybody blames that they're making excuses. But that is the time when the migraine starts. And surprisingly, the migraine is not only the headache. The migraine can present like there are certain migraines which can present like abdominal discomfort. There are certain migraines which like presents like a spinning sensation in the head. They constantly have vertigo lasting for the like hours. They feel like everything is spinning.
Right.
They have like certain people even don't have the headaches, no, don't abdominal pain, nothing, but they just have the like a very poor mood, very fatigue kind of feeling.
Right.
So that kind of thing. So we need to realize that the migraine can have a many multifaceted kind of this thing. We need to listen to the patient very thoroughly, like what are the aspects of his life are getting troubled with because of this condition, and we need to work around that, because not having headache is not the like aim of it. They should be having a absolutely normal life, a very kind of lifestyle where they can contribute to their like maybe
Right.
the development and everything.
Yeah. How interesting though that migraines decrease as you get older.
So it starts in the adolescent age, and by the time you reach 40s and 45s, the frequency of the migraine tends to decrease. So that is the pattern they have seen.
Yeah, I thought it would actually you'll get more migraines as you get older.
Yeah.
Maybe your spouse is your trigger.
Yeah, so that time I think the tension type headache starts. So, no? But yeah, so with the age, the frequency of the migraine most of the time tends to go down.
Huh.
Yeah.
Oh, that's very interesting.
So that's why if the elderly patient comes to you, that's like a 50 or 60 years of gentleman, if he comes to you that I'm having headache for a month and I think it's a migraine.
Yeah.
So you need to like reserve yourself, no, because the migraine mostly does not start at that age.
Yeah, that must be something a little bit.
So that is the age where the migraines should go down. If the patient comes to you that I have started these headaches and very recent onset headache, so you need to think beyond having the primary headaches. No, you need to rule out the other etiologies. Yeah.
Any myths that typically come to you for these kind of things that you
Because
like to break down?
Yeah. So most of the people think that the migraines are something which are very difficult to deal with, and why it is very difficult for them to like accept the fact if my MRI is normal, if you say my brain is normal, if you say that my mind is normal, then why am I having the headaches? No, tell me the reason for it. So that is the time the skills of the neurologist come in handy to like what our very much senior neurologist used to tell us, that how to you explain it to your like patient, no, that sometimes the patients are like some person are very sensitive, no, like if somebody like tells something or scolds them, no, they feel very bad.
Right,
and
right,
few
right.
people just don't worry about themselves.
Yeah.
So few people with the migraineurs, your mind are very sensitive.
Interesting. Okay.
So you can just explain those things, like you are being very sensitive to a certain trigger,
Right.
and there is nothing absolutely wrong in that.
Yeah.
So when they accept that thing, that it is just the trigger which is like having that effects. It's very difficult. It becomes easy to like accept that thing and the work around with that.
So I guess the takeaway for these migraines and things like that is that perhaps you can't avoid them to some degree, but the way to work around them is to try and be as aware of your trigger points as much as possible and work around them.
Yeah.
Which is encouraging. And of course, hopefully they
Age-
decrease.
age will
That's a very
decrease.
cool, interesting fact that I did not know yesterday. Thank you so much, Doc.
Yeah.
Any last words that you like to leave us with? Any thoughts that you like to touch upon that we haven't covered yet?
Yeah. So most of the time, like the primary headaches, migraine, TTH, TSCs are very common. But like we should not feel that if I'm having migraine, so like every headache I'm going to have is a migraine only.
Yeah.
So if you feel that your headache has changed in the character, or if your headaches are not like the headaches you used to be, or like you are having any other symptoms like along with the headache you are feeling like there is a weakness in the hand or weakness in the limb, if you feel your vision is not working properly, that is the time you should not stay at home and feel that it is just because of my primary headache or migraines. You should actually visit a clinician nearby and get yourself evaluated. Work on your lifestyle. It gives you better results.
Okay.
Yeah.
Thank you. That's a lovely thought to end on. It's been a very mindful episode. Thank you so much for being here, Doc.
Thank you,
I
sir, for the
appreciate
opportunity.
appreciate the insight that you've given us for a lot of people on a topic that is probably most common for everyone, and I think that's really helped a lot of people today. So thank you so much for being here.
Thank you, sir. Thank you for the opportunity. Yeah.
Thank you all, and before you leave, do not forget to hit the like and subscribe button here at the bottom. Any comments that you may have, please leave them as well, and we will see you all next week. Thank you.